Hi, I am Dr. Saqib Mansoor, and today I will discuss with you the clinical of the hip joint. In the previous video, I discussed with you the normal anatomy of the hip joint, and today the clinicals. Like this is the posterior dislocation, the calmness of the dislocation of the hip joint, and this is the prosthesis, the metallic prosthesis of the hip joint in the hip replacement. So to understand the stability factors of the hip joint, I will again tell you the congruity of the articular surfaces of the hip joint. And this is in particular reference with the bipedalism in humans. In humans, the acetabulum is directed inferiorly, laterally, and anteriorly. Here you could see, this is the direction of the acetabulum. And the iliac portion of the acetabular rim is weight bearing and situated over the femoral head, which is important in transferring weight of the femur in the erect position. This is the iliac portion of the hip bone, and this is the acetabular rim, and this is responsible for transferring weight of to the femur in the erect posture, right? As a result, the hip joint is mechanically in most stable position when someone is bearing weight. For example, as one lifting a heavy object. Reduction in the degree to which ilium overlies the femoral head, that is detectable in a radiograph as angle of Weiberg. It depicts joint instability. If this angle is reduced, this is the angle of Weiberg, right? This is the angle of Weiberg. If it is reduced, then there is would be joint instability. Owing to the anterior direction of the axis of the acetabulum and the posterior direction of the axis of the femoral head and neck, as it extends laterally owing to the angle of torsion, there exists an angle of 30 to 40 degree between their axes. We see in this, you could see this. This is the axis of acetabulum, right? This is the anterior direction of that, right? And you can compare it to the stem of an umbrella. This is axis of acetabulum. This is right here acetabulum, and it is axis. And the second is axis of head and neck of femur. This is head, and this is neck. These are two axes. This is the posterior direction of axis of head and neck of femur, and the angle between these two axes is 30 to 40 degree. So that is the way with it. So, and what is angle of torsion? This you already know in discussion of the femur. This is transverse plane or axis of the femoral condyles, and the second one is this axis of head and neck of femur. That angle between these two is the angle of torsion, which is the normal 7 to 12 degree. As a result of this, articular surfaces of the head and acetabulum are not fully congruent in the erect posture. The anterior part of the femoral head is exposed and articulates with the joint capsule mostly. However, seldom is greater than 40% of the available articular surface femoral head in contact with the surface of the acetabulum in any position of the joint. Compared to other joints and considering the big size of the hip joint, this contact is extensive, contributing significantly to the joint's immense stability. The 40% contact is in fact a great contact. Fractures of the neck of the femur. Now coming straight to the real clinicals, the fractures of the femoral neck, they are regrettably called as fractured hips, suggesting that the hip bone is broken, which in fact is not. They are uncommon in most of the contact sports because the players are usually young and the femoral neck is strong in people less than 40 years of age. When the fractures of the neck do occur at below 40 years of age, these usually are a result of high energy impacts. For example, during a race car accident, trampoline, and skiing, when the lower limb is in extended position and the force of the impact is transmitted to the hip joint, even if applied at a distance from the joint. For instance, during a head-on collision, if the foot is firmly braced against the car floor with the knee locked. If the knee is braced against the dashboard, the force of the impact can be transmitted in upward direction and result in a femoral neck fracture. Femoral neck fractures continue, and they are particularly common in persons over 60 years, especially in women, as their femoral necks are weak and brittle due to the osteoporosis, right? I will tell you the picture. Femoral neck fractures are mostly intracapsular, and the realignment of the neck fragments needs internal skeletal fixation. Here you could see the femoral neck. This is an old lady. This is the picture, and this you could see, right? So these can be result of a spontaneous fractures resulting in fall. So fractures of the neck of the femur usually interrupt blood supply to the head of the femur. So you could see the arteries responsible. This is the medial circumflex femoral artery, this over here, right? I already discussed with you in the previous lectures blood supply of the this hip joint, right? So medial circumflex femoral artery, it supplies these retinacular arteries to the this portion neck here, and this is the ligament of the head of the femur, and here lies the articular branch artery to the head of the femur in the ligament, right? This. So these retinacular arteries are often torn away when the neck of the femur is fractured or the hip joint gets dislocated. After some femoral neck fractures, artery to the ligament of the femoral head is the only remaining source of blood supply to the proximal fragment. This artery is usually insufficient for maintaining the femoral head nutrition. As a result, the fragment can undergo aseptic vascular necrosis of the head of the femur, right? Yes, this is insufficient to maintain the blood nutrition of this head, resulting in avascular necrosis of the head of the femur. So now the Coxa, Vara and Coxa, Valga, right? So let's see these two conditions. This is the Coxa, Vara, and this is the Coxa, Valga. Coxa Vara is a change of the angle made by axis of the femoral neck to the axis of the femoral shaft, such that the angle is less than 135 degrees, and in this way the neck of the femur becomes more horizontal, so decreased angle of inclination. So right, this is the angle of inclination. This is the angle of the long axis is the femur, and this is the angle of the neck, and this gets decreased. You could see there is the decreased angle, right? This is the decrease in angle. Where the reverse happens in Coxa Valga, this two axes result in an increased angle of inclination, right? Greater than 135 degrees. This is Coxa Valga, and this is Coxa Vara. So very important, surgical hip replacement, right? You could see this. This is the osteophytes are eroded and articular cartilage also eroded, and this is a moderate arthritis of the hip. There is the osteoarthritis, and this is, you could see here is the hip prosthesis, right? Here, this is the metal prosthesis. This is femoral head and neck, it's metal, and this is hip prosthesis, and the acetabulum is in a sort of plastic socket, right? So this is the hip replacement surgical procedure. Hip replacement, a metal prosthesis is anchored to the patient's femur by bone cement, replaces femoral head and neck, whereas a plastic socket cemented to hip bone replaces acetabulum, right? Let's few word lines about again this osteoarthritis, OA. A common cause of disability is osteoarthritis, OA, of the hip joint that is characterized by pain, limitation of motion, edema, and erosion of the articular cartilage. Here you could see all these characteristics, the osteoarthritis. They're pretty common here. So necrosis of the femoral head in children, very important. So the traumatic dislocation, the hip joint interrupt the artery to the head of the femur in children. Fractures that cause separation of superior epiphysis of femur can also cause an insufficient blood supply to the femoral head, and in the post-traumatic avascular necrosis of the head of the femur. As a consequence, incongruity of joint surfaces is developed and growth of at the epiphysis is diminished. These conditions, common in children aged 3 to 9 years, cause hip pain that can radiate to the knee, right? So I will tell you later very soon why this hip pain radiates to the knee. So now very important, dislocation of the hip joint. It can be anterior or posterior. So posterior is more common. Congenital dislocation is pretty common as well. It's quite common that occur in about 1.5 per 1,000 neonates. It is bilateral in about half the cases. It can be unilateral, of course. Girls are having it at least 8 times more than boys. Dislocation takes place when the femoral head is not properly placed in the acetabulum. Inability to abduct the thigh is hallmark of congenital dislocation, right? Whenever there is a congenital dislocation, so the neonate cannot abduct the thigh. The affected limb looks and functions as if it is shorter, as the dislocated femoral head is more superior than on normal side, producing a positive Trendelenburg sign. Hip looks to drop on one side during walking. I will discuss with you in detail the positive Trendelenburg sign with picture. So this is the congenital dislocation of the left hip joint. Here you could see looks shorter, right? And as the hip, this head of the femur is gone upwards, so this you note skin creases over here more than acquired dislocation, right, of the hip joint is uncommon due to strength and stability of the hip joint. Of course, we know that this is the strongest joint in the body with the most possible movement. Still, dislocation can occur during an automobile accident where the hip is flexed, medially rotated, and adducted, the usual position of the lower limb while a person is riding a car. So the posterior dislocations of the hip joint are commonest. When a head-on collision occurs, the knee strikes the dashboard that can dislocate the hip when femoral head is forced out of the acetabulum. Here you could see this. This is a head-on collision, and this you see the position of the limb. Here you could see in this bracket, small square, right? Here you could see, and this will result in posterior dislocation of the hip, this head of the femur, posterior dislocation, head of the femur. You can say posterior dislocation of the hip joint. The joint capsule gets ruptured posterior-inferiorly. That allows the femoral head to pass through the tear in the capsule and over the posterior margin of the acetabulum onto the lateral surface of the ilium, shortening and medially rotating the limb, right? Shorten the limb, medially rotated it. You could see this is rotated medially, this limb. So very important in the posterior dislocation of the hip joint, the point very important, the sciatic nerve is closely related to the hip joint, where it can be injured when posterior dislocation of the hip joint or fracture dislocation of the joint takes place. What will happen if the sciatic nerve is injured? Motor deficits and the sensory deficits. In the motor deficits, this sort of injury can produce paralysis of the hamstring and muscles distal to the knee that are supplied by the sciatic nerve. And the sensory deficits, these can occur in the skin over posterolateral aspects of the leg and over most of the foot due to injury to the sensory branches of the sciatic nerve. So the anterior dislocation of the hip joint. Anterior dislocation of the hip joint is a result of severe injury that forces hip joint into extension, lateral rotation, and abduction. For example, catching a ski tip while snow skiing. In these instances, the head of the femur is inferior to the acetabulum, right? Frequently, the acetabular margin gets fractured that results in a fracture dislocation of the hip joint. When the femoral head dislocates, it usually carries the acetabular bone fragment and acetabular labrum with it. These injuries are also seen with posterior dislocations. So, the very important sign, the Trendelenburg sign, it's need to be discussed in great detail and with great focus. So hip joint stability and Trendelenburg sign. When a person stands on one leg with foot of the opposite leg raised above the ground, the stability of the hip joint depends on three factors. You see this position, talking about this is the normal position. This is and the person standing on one foot, and now he has raised and the other foot, the other foot is off the ground. So this is the normal, and you could see here, you could see this whole position, the pelvis goes this upwards, right? And this stability depends on three factors. The gluteus medius and the gluteus minimus have to function normally, right? Of the opposite side, right? Here you could see these glutea have to function normally to keep this unsupported side upwards. The femoral head must be placed normally within the acetabulum, right? And the femoral neck must be intact, and the neck must have a normal angle with shaft of the femur. If any one of these three factors is defective, then the pelvis sinks downwards on the opposite unsupported side. The patient is thus said to show a positive Trendelenburg sign. Here you could see the Trendelenburg sign positive. Here you see this is here. This is no paralyzed. This is the opposite side, the supported side. The foot is on the ground, and here this is the unsupported side. And here you could see the pelvis sinking downwards, right? This is the pelvis sinking downwards of the unsupported side of the pelvis, and this is the positive Trendelenburg sign. If patient having bilateral congenital dislocation of the hip joint, the gait is a typical waddling gait. So the arthritis of the hip joint, a patient having an inflamed hip joint places the femur in the position giving him or her minimum discomfort. That is the position where the joint cavity possesses the greatest capacity to accommodate the increased amount of the synovial fluid secreted. So that position of the hip joint is slightly flexed, abducted, and externally rotated. Osteoarthritis is the commonest disease of the hip joint in adults that cause pain, stiffness, and deformity. As the obturator nerve supplies both hip and knee joint, pain can be in the hip joint itself, or it can be referred to the knee. It can both be in the hip joint and the knee. This is a referred pain. The stiffness is a result of pain and reflex spasm of the surrounding muscles. The deformity is flexion, adduction, and external rotation, and is developed initially by muscle spasm and later by muscle contracture. So referred pain cause from the hip bone, referred pain to the knee joint. What's the cause? Femoral nerve, in addition to supplying the hip joint, also supplies skin of the front and the medial side of the thigh through the medial and intermediate cutaneous nerves of the thigh. It is clear thus that the pain arising from the hip joint will be referred to the medial and front side of the thigh. Posterior division of the obturator nerve supplies both the hip joint and the knee joint. So this explains why the hip joint disease occasionally produces pain in the knee joint, right? So the two nerves, femoral nerve and this posterior division of the obturator nerve. Two nerves are involved in making this, producing these referred pain. injection or aspiration of the hip joint. It can be performed from the front or side. At the front, the needle is to be inserted 5 centimeters below the anterior inferior iliac spine and 4 centimeters lateral to the femoral pulse, being directed upwards, backwards, and medially. During lateral approach, the needle has to pass in front of the greater trochanter and parallel with neck of the femur, thus entering the capsule through lower end of the gluteus medius and gluteus minimus. Thank you very much for watching my video, and I ask you for the support. Please subscribe my channel and like and share. Do comment down below, and we'll continue the journey with good videos for you of the anatomy. Thank you very much. Stay safe.